by laparoscopic and robotic surgery for the pelvic organ prolapse and stress urinary incontinence. So I welcome ma'am.
Good afternoon, everyone. Okay. Can we have the presentation when you are ready? So while they are getting ready, we can talk about something else. So maybe we have few minutes. So while today we are going to talk about surgical management, so trainees should never think that they need to do all the surgeries or they need to learn all the surgeries. They don't know surgeries. That's why they are trainees. Okay, so nobody should feel ever bad that they don't know this thing or they are not skillful. So I'll give you an example. When I finished my MRCOG all parts, I was at that time I was working in Saudi Arabia as a junior house officer. So junior house officer means just writing histories and writing discharges, not even touching the patients. So I had no surgical exposure and I had no surgical skills, but because I had a lot of time on my hand, so when I went home, I really studied hard. So I went to the UK for a couple of courses and then I went for exams and luckily I passed MRCOG in first attempt. Now think about my situation. I have got the biggest degree and I know nothing. Like I have no surgical exposure because I didn't do any training in Pakistan. So when I went to the UK, then I came back to Saudi after passing my exam, and then from Saudi Arabia, I applied for a job. And the first job I got shortlisted was a clinical fellow in Obs and Gynae, which is like a registrar job in Wales, in North Wales. So I went for the interview, and in interview they asked few. There was the whole board in the boardroom, quite a few consultants, directors, everybody was there. So they asked me few questions, theoretical questions, few scenarios. I kept answering, and at the end I said, "Can I say something?" They said yes. I said, before you even think about giving me this job, you must know one thing. And they say, what's that? I said, I know nothing. I'm a very risky doctor to employ because I have not even done ever cesarean sections. I don't know how to do instrumental deliveries. I don't even know how to read CTG. So you might think I am MRCOG, but actually I know nothing, and that's the whole idea. I want to come here to get trained, but I don't want you to be in dark. So don't offer me this job if this is not acceptable to you, and I cannot do any on calls alone because I need someone to shadow, so who I can shadow. And they were shocked because people, when they go for interviews, they try to prove that they are the best doctor, their knowledge is best, their skills is best, their CV is best. So everybody went quiet in the room and they said, okay, thank you, and you wait outside. And then after 5 minutes, one of them came and they said, okay, we have decided to offer you the job. And they said, we will give you somebody for 3 months. You will do on calls with them and then you will shadow them. So I stayed in that department for 2 years, and everybody used to make joke of me that nobody has ever done an interview the way you did. That I know nothing, I don't know anything, I don't know cesareans, instrumental deliveries. I have never done this. I know how to take history, how to discharge a patient because I'm a junior house officer. So honesty is really important in whatever we do in life, and that is the only foundation of success. And we should never try to be someone else when we go for an interview. And the easiest thing to remember is the truth. So that always remember, when we are trying to be someone else in the interview, we will make mistakes. And easiest thing to remember is the truth. Always in life, when you are confronting someone, when you are in a court or when you go somewhere, the easiest thing to remember is the truth. So being honest is really important. Okay then, so let's start. I hope you're ready now. Okay, so the reason I told you this story because all the presentation today is about surgical skills and various surgeries which we are going to discuss. But never to get disheartened if there are some surgeries which you have never heard of or some surgeries which you don't understand. Because this is a journey. We all have to take this journey. And it is also said that even a journey of 1,000 miles starts with a single step. So this is the first step you all are taking in urogynecology, and you should have faith in yourself. And hopefully this journey will become easier and easier. And there is another quotation that well begun is half done. So if you start something with motivation and honesty, everything gets easier. So let's see what's there in this presentation. So we have been talking about various modalities so far. Conservative management, we have discussed quite a few things like weight reduction, awareness, health education, fluid management, pelvic floor exercises, pessary management, but definitive treatment of pelvic organ prolapse as well as incontinence is surgery. Okay, so the reason we emphasize so much for conservative management because surgery for prolapse and stress incontinence is not perfect. So at best, the success rate will be 70 to 80%. And if somebody is excellent, maybe 90%. And there are 10% risk of serious complication, okay? And then in total, 20-30% risk of minor to moderate complication. And some of the complications could be irreversible. That's why it's really important to know that it is not perfect. So sometimes we are better off with conservative management. So the problem with the prolapse is that no two patients are same. So one woman can have prolapse in one compartment but may not be symptomatic in that compartment. For example, somebody has a cystocele and she has not much symptoms of cystocele, but actually she has presented to you with stress incontinence. But when you have examined, you have found a cystocele. So she has prolapse, but she is not symptomatic. So that is also a dilemma, what to treat. Whether we treat stress incontinence or do we treat cystocele first. And also, sometimes there are multiple problems. In addition to stress incontinence, there is a rectocele, uterine descent, cervical prolapse, very elongated cervix. So first of all, we need to discuss with the woman what is bothering her most and then explain everything, the examination findings, and then decide. And also when we examine the patient on the couch, the degree of prolapse is less. When they are on the table, because of general anesthetic, all ligaments, tendons, and muscles are relaxed. So usually what we find is a lot bigger prolapse than what we expected in outpatient. So how do we choose which surgery? So first of all, what are the things which are affecting her quality of life? Extent of the prolapse, whether she has completed her family, are we going to conserve her fertility like uterine sparing surgery, or are we going to consider hysterectomy first? Is she sexually active or not? That's the most important point because some of the surgeries like colpoclysis we cannot do if somebody is sexually active. Age of the patient, for example, if very young patient, we need to keep the vagina functional. Fitness for surgery, if somebody has cardiac disease, can she go through surgery, or whether is there any surgery we can do under local anesthetic. Associated incontinence symptoms, women's goals and expectation. Last week, just before I came here, my last theater list, I was so humiliated because one of our own nursing manager, she was there on my list. And I saw her 1 year ago because in UK it doesn't happen that if you are a member of staff or if you have someone knows you, you will jump the loop. It will not happen. Everybody has to wait the same time. So on the day of surgery, I said, you are coming for a prolapse repair. She said, yes. And I looked at the notes and it was just posterior repair. I have documented she's coming for a posterior repair. I did her posterior repair. And what happened after surgery, that I got a call from recovery that this patient would like to see me urgently. And I went there and she said, oh, I'm so shocked. You have done my surgery, but I'm still leaking. And I said, what? I did not do any surgery for you to stop leaking. She said, no, that's what I was expecting, that my prolapse will go and my leaking will get better. I said, posterior repair doesn't do that. She said, no, but this is what I wanted and I'm still leaking and I wasted such a long wait. And you know, over there people are very upfront. they are very confrontational if their expectations are not. And I felt so humiliated that after spending 11 years in urogynecology, I could not meet her expectations. She was expecting that after her prolapse surgery, her incontinence got better. And maybe I did not clarify this to her. I should have been a bit more clear. There was some breakage of communication, but I really felt humiliated, and I apologized to her. Usually I see patients 3 months for routine follow-up, and I told her I'm going to see you in 6 weeks' time. We'll talk about it and we will see what we can do. But I'm telling you, you may consider me as an experienced urogynecologist, but even in my daily practice, sometimes people can be shocked that their expectations are not met. So women's goals and expectations, that point is really important. Work, physical activity, domestic circumstances, previous management and outcome, and surgical experience and familiarity with different surgical procedures. The last point is really important for the surgeon. Do the procedures you are familiar with. Don't do the procedure which you are completely new or you have never seen, because you will be in trouble, because troubleshooting is really bad in urogynecology. General rule. So we give antibiotic cover, but only one antibiotic shot we give during surgery. We don't give 5 days of antibiotics or 3 days. It is just one antibiotic when we are inducing for general anesthetic or spinal anesthetic. Thromboprophylaxis is the most common one because DVT is a common problem after any pelvic floor surgery. So this is the top of the list. Everybody has Clexane for thromboprophylaxis, and everybody has TED stocking. Do we have TED stocking here? Like special stockings to prevent thromboembolism? Do we have here or? Okay. So they are 100% must there. Even for day case surgery, they have TED stocking, and major surgery, they have to put on those stockings for 6 weeks and 7 days of Clexane. And if they have a risk factor, for example, antiphospholipid syndrome or any other problem, then they have 28 days of Clexane. So we have to discuss route of the surgery, which is vaginal, abdominal, or laparoscopic. Anesthesia we have to discuss. The good news is that a lot of surgeries nowadays I do under local anesthetic, and a lot of things we have moved to outpatient setting, which is really great. Since we started doing colpoclysis under local anesthetic, that has transformed the service for women. And a lot of surgeries are day case surgery. I don't know whether you do vaginal hysterectomies at day case? No. So all of my vaginal hysterectomies we do as day cases. So unless the patient is last on the list, because my list timing is 8 a.m. till 5 p.m. So if I have done her after 3 p.m., then I keep her overnight. But if I have done her before lunchtime, they go home. Everybody goes home same day for all the surgeries. All urogyne surgeries apart from sacrocolpopexy and autologous facial sling. So all surgeries are day cases. Fitness for anesthesia, as we discussed earlier. Bladder care. Because our surgeries are day cases, most of the cases we do not put any catheter. And this also has transformed because it has reduced the risk of urinary tract infection a lot. So after vaginal hysterectomies, we don't put any catheter. We just do in and out catheter at the beginning of surgery, and that's all. Sorry? So no catheter at all, no vaginal packing for any anterior repair, posterior repair, perineoplasty, vaginal hysterectomy. So no catheter, no pack, and these are all day cases. Sorry? Yeah. Yeah, but if you think about it, vagina is not a sterile place. It can't be clean. Yeah, so that's I think some things we can learn from each other. Yeah, but all of these surgeries can be done at day cases, which will be so beneficial because we have no beds in hospital to keep the patients in. So all of our laparoscopic abdominal hysterectomies are day cases as well. So all laparoscopic hysterectomies are day cases. So if there is a bladder injury, which then they require catheter for 2 weeks roughly. If patient is unable to void, then or there is a post-void residual after vaginal hysterectomy, then we put a catheter before they go home. Still they go home with a catheter and they come after 3 days, or we teach them self-catheterization. So self-catheterization is used a lot in the UK, a lot. For all the voiding dysfunction patients, we have a specialist nurse. Her job is just to teach self-catheterization and provide patient a little mirror, and there is a little kit and all the disposable catheters. So if there is bladder injury, it needs a cystogram prior to trial without catheter to ensure healing. So post-operative advice is to avoid heavy lifting, strenuous exercise, prolonged straining. For 3 months, avoid sexual intercourse for 6 to 8 weeks after surgery, and avoid smoking and manage diabetes, healthy diet. And everybody who has urogyne surgery, without fail, everybody has, we provide them 6 weeks of laxatives. So laxative of choice for all patient. Every single patient goes home on docustrate sodium. So just one tablet a day. We tell them your stool must be really loose. We don't want any constipation. Any straining, any stitch breaks, then it's a risk of recurrence. So 100% everybody has 6 weeks of docusate. Okay, so this is an important document. It is available online. This is called Surgery for Uterine Prolapse Patient Decision Aid. So all the trainees should make a note of this because this is like nearly 20 pages. So it is for patients to choose that what surgery would they like. There are mention of all types of surgeries, which I'm going to mention anyway. But in this document, it is very, very easy. Lay terminology is used. So we use these two documents, surgery for prolapse and surgery for stress incontinence. These nice, and we provide patient in outpatient with this document. We give them all the option, and then we have a phone consultation in 2 weeks' time to see which surgery they would like to choose. So again and again, the NICE says that different treatment options must be discussed with the patient. So different treatment options must be discussed with the patient. We should never assume, oh, we think this is a good option for her. We should never assume. Because you are very lucky here in India because there is no litigation. Over there, if there is a litigation, everything from the very start, judges will have a look that when the patient came, what options were discussed, whether she was offered conservative management or not, is it documented that she was offered and she declined? Yeah, so it's really important that all options are given and it is documented why we have chosen the option, what we have chosen. And benefits and risk of each surgical procedure, including changes in urinary, bowel, and sexual function, must be documented. The risk of recurrence, uncertainties about long-term adverse effect, particularly those involving mesh. So in the UK, if you use mesh for any procedure, the only procedure which is allowed at the moment is abdominal sacrocolpopexy. The patient must have yearly follow-up lifelong of the patient. Can you believe that? Till that patient is alive, every year we have to give her one follow-up appointment every year. It is such a huge workload. So everybody is reluctant nowadays to use mesh because then it is the patient is attached to you lifelong. And there is no other mesh which is being used in any gynae practice in the whole UK or at least England, because in Scotland and Ireland some people have restarted using TVT, which involves a mesh, but in the UK it is illegal. If anybody puts any mesh in the vagina in the form of TVT or anything else, it is a crime and you will go to jail. So it is that extent. So at the moment, nobody is allowed to use any mesh in the vagina. So sacrocolpopexy mesh, you have to get special approval, only then you can use it. Okay, so we are talking about pre-op factors.
Dr. Asha, what is the reason for lifelong follow-up? Is it because of the erosion by the
Yeah.
mesh or the surrounding area?
10% of the patient where we have used sacrocolpopexy mesh, they can have mesh exposure. In the past, we used to use the term erosion. Now the term is mesh exposure. And obviously, the people who are sexually active, if they have mesh exposure on top of the vagina, they can have dyspareunia to both of them, both partners, and it can cause excessive discharge and bleeding. So because
We've
of
done
those,
a sacrohysteropexy.
yeah.
In that case, also lifelong follow-up is essential. Uterus is there. We have not exposed the
No.
mesh anywhere. It was just the
Yeah.
uterus between the
Inner mesh, yeah.
sacrum and sacrum, and everything is now retroperitoneal and fibroblast and fibrosis that takes place. So the risk is very less. But do
Exactly.
those cases also need lifelong follow-up?
In UK, any sacrohysteropexy or sacrocolpopexy lifelong follow-up, but everybody knows that after sacrohysteropexy, which is becoming rarer and rarer, people not doing it as much.
Nulliparous prolapse.
Yeah, nulliparous prolapse.
Yeah.
And yes, they need to be registered with MHRA.
In our country,
Yeah.
Incontinence, but for nulliparous prolapse, uh, we are doing it.
Mm-hmm.
At least I am
Yeah.
doing it. I've done it recently in 2 cases, but I never ask them to have a lifelong follow-up. That's why I will inform them.
Yeah, yeah, yeah.
I'm in contact with them, and I will, if that is required, I
Yeah.
do
So
that.
while we are still getting electricity back, we will continue talking about pre-op assessment and anesthesia and various things which we can do to help our patients where there is serious comorbidity involved in decision for major surgery. So let's talk about something which is the commonest operation which I do, which is actually the very last slide of the presentation. But we can do that first because by the time electricity will come and we will reach to that slide, maybe we all will be very tired. So the operation I'm talking about is colpoclysis. Is it a common practice to do colpoclysis here? No. So, well, I can tell you if you have a patient who is above 70 years of age and who is not sexually active and she has prosidentia, I feel personally doing a vaginal hysterectomy in that patient is killing an ant with a cannon. That is such a major surgery for that patient. If she is not sexually active, you should never do vaginal hysterectomy for a woman over age 70. The reason is because once you do vaginal hysterectomy, because there is apical weakness, there is significant risk of vault prolapse after that, and also significant risk of urinary incontinence. So all of my patients who are not sexually active and usually above age of 70, I offer them colpoclysis. And colpoclysis is, if you read in the book, it's a very complex procedure the way it is documented. And that's why it is not practiced worldwide. But since I became a Urogyne consultant, I simplified the technique. And this is the commonest surgery which I do. So, for example, in last few years, I have done more than 200. So everybody knows that this is my favorite operation, and it is either for vault prolapse, it is equally good, or if it is for prosidentia. Even minor degree, because the way I have tweaked my technique, even asymmetrical prolapse, I do colpoclysis. And the best news is I do it under local anesthetic and as a day case. So what happens then? Patient has it done, and she goes home. And my oldest patient is 97 years old who had prosidentia, and for last so many years she was using pessaries because nobody will touch her because she had cardiac disease and she was not fit for anesthesia. So it took me 40 minutes to do colpoclysis under local anesthetic. So all of you, if you need to learn one thing from today's lecture, never underestimate colpoclysis and never do vaginal hysterectomy for women who are not sexually active. Consider colpoclysis.
One question, excuse me. In colpoclysis, do you not have a problem in later on developing any malignant lesion in the cervix? Number one, and number two, the stress incontinence.
Yeah. So these are very valid
There
questions.
is traction on the anterior wall of the vagina.
Yeah.
So these two things are worrying me.
Exactly. These are very good questions. So, what it is, there is, if you look at the incidence of cervical cancer and endometrial cancer, and if you look at the peak ages, they are before 70. So a woman who hasn't developed cervical cancer and endometrial cancer before 70, it is extremely unlikely she will have cancer again. So that is one point. So all the cases I did, or nearly 200 cases, it was presented in a conference in Singapore, and I think my trainee got the award for that. Only one patient out of all those 200 patients had postmenopausal bleeding. So we had, obviously she can't have transvaginal scan. So we did abdominal scan, and still endometrial thickness was less than 4 millimeter. So she did not need any intervention. So if after colpoclysis, if they need hysterectomy, they have abdominal hysterectomy if they need. So after transvaginal scan, we do MRI if there is any suspicion of thickened endometrium, which is more than 4. And if MRI is normal, then nothing needs to be done. And stress incontinence, so when you are doing colpoclysis, you need to leave at least 3 centimeter area under urethra where your triangle is closing. If you leave less than 3 centimeter, then you have stress incontinence because then urethra doesn't close properly. There is a traction. So you must leave 3 centimeter under urethra. So your front triangle should be starting a bit low. Yeah. Okay. So what I will do, I will draw a picture in the end to show my simplified technique of colpoclysis. So maybe that will help a lot of patients. Okay, so we are talking about various factors. Now we are talking about incontinence. Whenever we do prolapse surgery, as madam has correctly mentioned, people have risk of incontinence. They didn't have incontinence before, so they have swapped one problem, which is prolapse, with incontinence. And it's terrible, isn't it? They would say at the end, it was better for us to have prolapse than to have incontinence. Why did you do this to me? So you must tell them that this surgery is associated with risk of incontinence, any prolapse surgery. But you need to make your mind clearly, is it worthwhile having the risk of having incontinence? And you also tell them, if prolapse is very bothersome, yes, we can agree to do surgery. And if you develop incontinence, you will need later investigation in the form of urodynamics. And then we can offer you surgery for overactive bladder or stress incontinence. So you give them hope as well that if you develop incontinence, we can do something about it. So that's another thing. Sometimes there is some consultants do concurrent surgery for stress incontinence and prolapse in women who have anterior or apical prolapse and have stress incontinence at the same time. The example of this will be somebody has a cystocele and somebody has stress incontinence. So they have had urodynamics, which has confirmed stress incontinence. So some consultants do anterior repair, and at the end of the anterior repair, in the past, they will put a TVT, or now they will put a sling operation. Yeah? I do not do that. The reason is because all of us who do urogyne surgery know whenever somebody has cystocele and have incontinence, there is 50% chance that just doing a cystocele repair will improve her incontinence. 50% chance, which is very significant. So I always do single surgery. I never do concurrent surgery. Because if patient is lucky, but you must tell them that you have got good 50% chance your incontinence will get better. If it didn't, don't worry. I'll see you in 3 months. We can investigate you and we can offer you surgery for stress incontinence or overactive bladder. But as Dr. Seema was mentioning, Kelly plication and all that at the time of anterior repair. So if you... Yeah, yeah. So I heard that is a common practice in India. Okay, if woman's chosen procedure is not available from the consulting surgeon, refer her to an alternate surgeon. This is something of ethical value. For example, in UK, in order to have super specialization in certain procedures, procedures are divided in between colleagues. For example, in our organization, I'm the only consultant who does autologous facial sling. So if any of other urogyne consultants patients has chosen a sling operation, after she is given all the option, that patient will come to me. And I don't do Birch colposuspension. Just my personal reason, I just don't like the idea of that operation. But when I give my patient the document of surgery for stress incontinence, decision aid, and she has chosen Birch colposuspension, I send her to my colleague who does it. So it is just ethical practice. So at the end of the day, patient is happy that what she has chosen, she has been provided with. So it is about concurrent surgery, combined procedures, and must thing is a follow-up after surgery. I don't know in India whether it's a regular practice to have a regular follow-up, but in the UK you must have 3 months follow-up because you have to enter this data on British Society of Urogynecology website. Okay, so let's go to traditional anterior repair type of procedure. Nothing special in this slide, and we will see a video in a minute, and that is a nice for junior trainees to have a look. So rather than looking at this description in words, we'll have a look at a little nice video. Okay, so let's have a look. Let's play that little video at the end. So I think it is the one which I'm thinking, if it is on a mannequin. The one on the link is there, yeah. Sorry, it is the link at the bottom of the slide, this one. I hope it is the same one what I'm thinking. Yeah, this is the one.
Patient in dorsal lithotomy, place Foley catheter for recognition of the urethrovesical junction. Use 2 Alice clamps to grasp the vaginal epithelium at the urethrovesical junction and at the vaginal apex. Inject hydrodissection solution subepithelially. I use 20 units of putrescine, 20 cc's plain 0.5% marcaine in 100 cc's of normal saline mixture. I typically use 20 cc's of mixture for the hydrodissection. With a scalpel, incise the vaginal epithelium between the 2 Alice clamps, from the urethrovesical junction to the apex. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Surgical tips. Place an Alice clamp on the epithelial edge. Using your forefinger as traction, use Metzenbaum scissors to carefully dissect the fibromuscular layer away. An assistant can maintain traction medially on the underlying muscularis tissue layer with atraumatic pickups. Providing traction and countertraction is very important for a clean dissection. Dissect the underlying vaginal muscularis from the epithelium to the margins of the dissection bilaterally. Delayed absorbable suture. Plicate the prolapsed fibromuscular layer in 1 or 2 mattress layers. Surgical tips. Avoid tension and avoid taking excessively deep bites to prevent injury to the underlying trigone and ureteric orifices. If the prolapse is particularly large, consider placing an initial purse string suture. Trim excess vaginal epithelium and re-approximate the vaginal epithelium with 2O or 3O delayed absorbable suture in interrupted, subcuticular, or running fashion. Perform cystoscopy for evaluation of bladder integrity and ureteral patency.
Thank you. We can go back to presentation. All right, so venous plexus bleeding, although she injected quite a generous amount of pitressin, which is vasoconstrictor, If it is not available, we can also use adrenaline solution along with bupivacaine. So benefit of bupivacaine will be because we do it as or daycare surgery, so it's not painful for the patient. So I use 0.5% bupivacaine with 1 in 200,000 adrenaline in a total of 20 to 30 mils. And sometimes venous plexus bleeding can happen. Most of the time, if it is a daycare surgery, we have to sort that out. We cannot use diathermy too much, so we use 2-vicryl to put stitches rather than using too much diathermy on anterior vaginal wall. Cystoscopy is not a routine. In my cases, when I do anterior repair, but if I have done very extensive dissection, then I do cystoscopy, but it's not a routine procedure. So if you use a lot of diathermy, there is risk of development of fistula. So we need to try to avoid diathermy in vagina. And again, stress incontinence might be unmasked with correction of urethral kinking associated with vaginal wall prolapse. Okay, so success rate initially when they say 100%, recurrence rate of 40%, 43% was reported. So anterior repair is the one with the highest failure rate in all of the prolapse surgery. And this was the area of my research. So my research paper, what are the reasons why anterior repair fails? So it was a biomechanical study. So we took pieces of the trimmings from anterior vaginal wall from various patients when we did repair surgery, and we analyzed these in the lab to see biomechanical properties of the tissues and amount of collagen, to see later on which patients developed recurrence. And then we compared, so it was period of 3 years, and then we compared what was the collagen quality, quantity of collagen, and bioelastic characteristics, and whether there was any correlation with recurrence. So good news was that there was no correlation. So we cannot blame collagen, that it was collagen or biomechanical elasticity problem. That's why people have recurrence. So this means it is surgical technique. And top of the list is if we do not correct the apical support, anterior prolapse will always fail. Okay, we'll talk about that. Let's go forward. Posterior compartment. So it's exactly same type of technique. The reason it is a busy slide, it's for trainees because you are going to get a soft copy. So these are the surgical steps, but all the experienced people, obviously they do this routinely. The main thing is whenever you do posterior repair, my tip will be do not excise any excess skin. Anterior repair, you can get rid of excess skin, but in posterior vaginal wall, no matter how much loose skin is there, do not trim it, because that is the leading cause of dyspareunia, because then it causes stretching and scarring. So do not trim it, no matter how loose it looks. If you have approximated the fascia underneath, the loose skin will get caught and it will get better with passage of time. So do not trim the skin. And sometimes genital hiatus correction is really important. If genital hiatus is more than 4 centimeters, a tight perineorrhaphy is really important to give support at the end of the posterior repair. So again, bleeding and small bowel injury, fistula, infection, recurrence, these are the risk factors. But the top of the list is dyspareunia, which is usually the result of a tight repair with excessive vaginal narrowing. Women can try lubrication and vaginal dilators, but may eventually need Fenton's repair to correct the narrowing at the introitus. So recurrence rate is 13% to 22%, and bowel dysfunction. So sometimes the obstructive defecation does not get better after posterior repair, because as we were discussing yesterday, people sometimes need splinting or digitation to empty their bowel. And when we tell them we are going to do posterior repair, they hope that after posterior repair they will be able to open their bowel easily. It does not happen in every case, because sometimes the etiology of that is rectorectal intussusception and not the rectocele. So if you have done a good rectocele repair and when you see her for follow-up, the prolapse has completely gone, but the symptoms have not gone, then you will request MRI defecography, and which will diagnose rectorectal intussusception. If you talk to radiologists, it's very easy to do. All they have to do, put some contrast in the rectum, make the patient sit in a commode and do MRI when she is passing it. So it will diagnose intussusception, which can be corrected by colorectal colleagues. So now the next video is about posterior repair. I don't think there is any need to see that. It is similar to what we saw. Unless somebody would like to see posterior repair, I think it will take long time. We'll move on to interesting stuff later on. Okay, so now we are talking about vaginal hysterectomy. Obviously, this is one of the favorite operations what urogynecologists do. Um, but if there is apical weakness, vaginal hysterectomy does not solve the problem. So after vaginal hysterectomy, as Dr. Seema was mentioning yesterday, we must do McCall's scaldoplasty, and there are various techniques which can be done like uterosacral ligament plication, McCall's scaldoplasty, and the technique which I have learned from my teachers, the one I do is a bit different. So I'll talk about that in a minute. It is similar, but it is a bit different. Gives us good result. Again, these steps are for trainees.
In rectocele repair also you do something like
Anchorage suture.
yeah.
Shall I mention that?
Because on the
Yeah, yeah.
LOA position you said is more common, so
Yeah, yeah.
left side fascia is more torn and
Yeah,
goes
yeah.
higher up.
Yeah, yeah.
And you search that and plicate it with
Okay,
the
so let's
vagina.
mention that. That is called, the name of that technique, I have forgotten. It's an Indian consultant in Southampton, and he started that. So he said it should be named after him. He's a nice chap. So, but we just call it anchorage suture. So, what we do, once we have done a good dissection and all the fascia is in front of us, let me make a little picture there. So it will be easier.
That step is important.
Oh, I'm impressed you remembered that, Dr. Sima. Okay, so this is our patient. This is urethra, and this is where we are operating. And this is anus, and as you can see. So we have opened up here, yeah. So we have done a lot of dissection. So we have got a fascia now. This is all dissected fascia, like that. And this is the upper margin of the posterior wall. So just think about interior wall, there is no prolapse, and we can see cervix is there, okay? So we have dissected up till cervix, right in the pouch of Douglas, we have gone there. And what we realized, that one-sided fascia, there is a break there, so there is no attachment. This side is attached there, but there is a break of this fascia. So unless we correct that part, nothing will happen, no matter how good plication we do. So the first stitch after dissection, what we do, we take to a vital, we take a bite from here, we take one single bite from there, we tie 2 knots, not 3, in the midline, so this becomes joined like that, and then we take the needle out here in the vagina. We get the needle out here, we take another bite, and we come in the vagina. So what happens? This broken fascia gets attached to the top of the vagina, close to the cervix. So this is the first anchorage suture. Then I'll take one suture here, one here, get out there, one anchorage suture here, one anchorage suture here, one here. So the break of fascia just underneath the cervix, I will lift it up with 3 anchorage suture. I'll come out in the vagina, go back into the vagina and tie 3 knots. So 1 knot there, one there, one there. So this means the break here, which was the reason when the baby says pass through or something, that area, the area there was nothing, I have filled that. So that also does a good job for prevention of future entrocele. Yeah, because you think about it, we are right in the posterior fornix. So these 3 anchorage suture, they help prevent. And once I have done that, then I do a normal plication. Just a normal plication, like that. But at the end, you must, when I do posterior repair, Dr. Seema might remember, I never start with a vertical incision. I always start with a diamond shape incision from the perineum. No matter whether they need perineorectomy or not, I always start the section. I just make a tiny slither of skin away. I make a rectangle. I remove this triangle, remove this skin. Then I do infiltration and then I start dissecting upward. And when I start suturing, I put these 3 anchorage suture and then I start the plication. So that is just a little tip which you remember. But usually good results. Okay, so now let's go back. Sorry about this busy slide, but I'm sure there is a use for it. Okay, let's go to the next slide. So we are talking about complication. As we know, bleeding can happen, bladder bowel injury. voiding dysfunction, recurrence of prolapse, dyspareunia, conversion to laparotomy. We are talking about vaginal hysterectomy here. Has anyone had any huge hematomas after vaginal hysterectomy or after repair? No?
Long back when I was a PG, I witnessed one case where both the side uterine vessels they slipped, and she was a very old lady,
Hmm.
and she had bilateral broad ligament
Yeah.
hematoma because we used to go for post-operative round in
Hmm.
the evening, the day our consultant used to operate. So when I saw that patient, she was absolutely pale and in shock. And
Hmm.
I had to call that time, lot of phone calls and all, they were not there. So she was attending some function. I ran, I called her there, and then she was operated. So that was only the one
Hmm.
case where I saw
Hmm.
bilateral broad ligament hematoma due to slippage of
Yeah, last year I saw one. It was a retroperitoneal hematoma after vaginal hysterectomy. And the patient's HB dropped by 6 points and she was in shock. But on examination, vaginal examination, there is no hematoma. Pelvic examination, there is no hematoma. Because when it is retroperitoneal, you can't pick it up. So you have to have an MRI scan which confirmed 20 centimeter retroperitoneal hematoma. But most of the time retroperitoneal hematomas are managed conservatively. You never open them up. So you just give her blood, give tranexamic acid, give antibiotics to prevent infection, and she was perfectly fine in 3 days' time and she went home. So no surgery needed. Okay, so these are the vault hematoma after vaginal hysterectomy is fairly common. If you sorry? Conservative, always conservative, retroperitoneal hematoma. So conservative means you keep checking her hemoglobin every 12 hours, give her 2 units of bloods, keep checking vital signs, give antibiotics, and give tranexamic acid. So mostly retroperitoneal are never open because where are you going to open is tricky. But before that, in order to manage them conservatively, you have an MRI scan before that. That is vital. And it is with contrast to see if there is a spurting vessel or not. So if there is a spurting vessel which is continuous bleeding, then you go and manage it with embolization. Still you don't open them. You do embolization from groin, and then if there is no spurting vessel, you just manage them conservatively.
Is the reason like if infundibulopelvic ligament from there, if the hematoma is forming, that goes retroperitoneal and up, and it is mostly not recognizable from the
Exactly,
bleeding itself.
exactly. Okay, so uterine preservation procedures, as Dr. Seema was mentioning, without hysterectomy we have to manage. So it is fertility preserving surgery, and it also reduces morbidity when we are not removing uterus. Okay, so dissection needing for hysterectomy may cause pelvic neuropathy and disrupt natural supporting attachment to uterosacral ligaments, leading to increased risk of urinary incontinence, prolapse, and sexual dysfunction. So we should never take hysterectomy lightly, and we should try to avoid hysterectomy because uterus does have some function in various ways in bowel and bladder and sexual function. So sacrospinous hysteropexy. So we have a device here, somewhere here. Dr. Shazi, can you pass me through this Capio device? That's the one which is open, the opened one.
Dr. Nisha, acha wo diya.
Oh, I got it actually. I remember. So the device which is shown here, I brought one with me. So that's what it is. That's all it is. This is called Capio device. Yeah. So it is Boston Scientific which makes it. So it is self-anchoring device because when you do sacrospinous ligament fixation with Meyer hook or dissection, it's a lot of dissection and it is risky because of neurovascular bundle there, and it is a lot of hard work for the surgeon. With this it is so quick. So what you do, all you need to do, you feel where ischial spines are. Yeah, if very obese patient and you can't feel spine, then you are in trouble. But you need to try to feel the ischial spines, and then you start going your dissection on the posterior vaginal wall. You try to go, but actual extent of the hole is only that big, because you don't need to see it. You just need to feel it, and with your fingertip, you do the dissection. You keep going, you keep cleaning, you keep try to reach the spine. Once you have reached the spine, then your left hand finger, index finger, goes there in the spine, and with the right hand, there is a special suture there, which is not a needle, it is like a small bullet. So it is like 2-3 millimeter only. So which is capio-polypropylene suture. So you can barely see it. I'm sure you can't see, even I can't see. So it's such a small bullet. So what you do, you mount it like that. And now I have mounted it. And the way you check whether you have mounted it well, it should not be pinching on your needle. So it's not pricking me. This means it should go completely in. And there's this thread. This goes in a groove there. So there are 2-3 grooves, one there, one there, one there, and one there. So now you think about it, it's like an arrow, isn't it? So now you are holding it like that with one hand, and this hand is going there where the spine is. For example, ligament is just there. So my finger is on the ligament, and then I go in there because it only needs a small space. This is Capio Slim. Original version is a bit thicker. So I go to the ligament with my finger, I guide my capio, that yes, this is the ligament, and then I fire it like that. So what it does, the needle will go through the ligament and the device will bring it back. So it will loop it. And then I take one more. So I take 2 stitches on each side. You can do unilateral, but I usually do bilateral. So I do dissection right side as well as left side. So I put 2 stitches on each side. My theory is that the vagina remains symmetrical. So it is aligned in the midline and it is easy, and then I don't have to put too much tension on 2 stitches because I have 2 on each side. So likelihood of success is higher. So similarly, this I am telling you for vault prolapse. But if there is cervix, when I take the stitch on the sacrospinous ligament, then on the other end of the stitch, there can be a needle, or you take free Mayo needle, you put it in the needle and you take a bite on the back of the cervix. And then you tie it inside vagina because this is not a dissolvable stitch. And then Dr. Seema yesterday beautifully explained how you close it on top of it. So it can be done with the uterus in, which is sacrohysteropexy, or sacrospinous hysteropexy, or you do it for vault prolapse, which is sacrospinous ligament fixation. So hematoma is a complication, bowel injury, right buttock pain. So you must write that on the consent form, right buttock pain, because if it happens, it's quite a bad pain. Luckily, it doesn't happen very common. Just 5% of patient may develop it, and it should get better within 3 months. Small proportion of women, it never gets better, and you have to remove the stitch. I've never removed it, but you need to know theoretically. So when you do sacrospinous ligament fixation, later on people can develop anterior prolapse because now all the traction has gone to the posterior, so anterior prolapse can develop. Similarly, when people have Birch colposuspension, later on they can develop posterior vaginal prolapse. So whenever we disturb one compartment, other compartment can be compromised, and you must counsel patient that this is not the end of the story. So what this slide is discussing, if you avoid hysterectomy, you save a lot of blood and morbidity, quicker recovery, less pain, and RCT is mentioned for trainees to make a note when you have a soft copy of this. Manchester repair. I'm sure you all do this. Yeah, this is one of the beautiful operations which has low morbidity, and I really like it. And I'm sure a lot of people, even trainees, would have seen this. It is done. You have to choose your patient well. It cannot be done when all the uterus is lying in the vagina and you try to do Manchester repair. It is only isolated, elongated cervix. Okay, sometime for some strange reason, cervix does grow in some people. So uterus normally present where it should be present, it is elongated cervix. And the test is you can see the whole cervix outside when you do the speculum. It should not be a globular appearance which you see with the uterine prolapse. So you have identified isolated elongation of the cervix, then it's a good procedure. There is a video there, but I'm sure you all can make a note of this link when you have soft copy and look at this video on YouTube yourself. Sacrohysteropaxy. So again, when we are trying to save the uterus, so we can wrap around the mesh. What mesh do you have in India? What type of mesh you have? Polypropylene, the blue color, and Y-shaped mesh.
We make it Y shape.
Okay.
It comes in triangular and we make it
Okay.
Y
Okay.
shape, and according to the distance that we adjust it.
Okay.
That's what is done.
So we in the UK we have stopped using polypropylene meshes. We have started using Dynamesh. So it is half the weight of polypropylene mesh, and it comes in the form of Y. So if there are any expired one, I'll bring some next time. So it's quite nice, less risk of erosion or exposure. So abdominal sacrohysteropaxy, we wrap the mesh around cervix, we attach the mesh to cervix, we go through broad ligament, and then we attach the mesh to the anterior longitudinal ligament on front of the sacrum.
Actually, attaching this Y, people have different opinion where to attach this Y.
Exactly. Hmm.
So some people, like what we do it, one side we attach to the uterosacral ligament, the other side we bring medial to uterine. We don't disturb the uterine vessel.
Hmm.
We bring medial to uterine, we pass it through the broad ligament, bring it anteriorly and attach to this
Front of the
area.
cervix.
So
Yeah.
with this, there is very nice pull onto the uterus, and it is well version, yeah.
Yeah.
Uterus is nicely anti-verted, anti-flexed, and the other part, of course, to the anterior ligament of the sacrum at the level of S5, S4, S5, at brim,
Okay.
sacral
So do
bone.
you recommend cesarean?
Yeah,
Okay.
yeah,
So you counsel them very well that
yeah.
they must never try to have a.
Our patient conceived, she had delivered one,
Okay.
and again she is pregnant.
Okay.
Yeah.
That's good. Laparoscopic approach is easier in a way that the view is beautiful on laparoscopic approach. So it's easier to dissect the sacral part because of the gas, all the bowel is away and we can see beautifully. And sometimes you can use tacks to attach the mesh with the little screws to the sacrum, but the better is to use ethibond. So there is a video again. If somebody wants to see, I can click it. Otherwise, later on you can see in the link. Otherwise, we'll be here all evening. So post-hysterectomy vaginal vault prolapse surgery. Uh,
Tell us that also. How do you suspend the vault after vaginal
yeah,
hysterectomy?
so that's what I was
Because
trying
that
to.
was also your.
My technique is a bit. This I learned from my teacher in Plymouth. So let's have a look. So that's quite a unique. I don't know whether you saw me doing that vaginal hysterectomy because 100% I've used the same technique. So it's quite interesting and it's very easy. So what happens? So how to draw that now? Yes, so this is our pedicle for cardinal ligament. We have already, cervix is somewhere here, yeah? And this is our pedicle for uterosacral ligament. So we have separated cervix from uterosacral first and then cardinal, yeah? So uterus is here. So normally people cut the suture. So I don't cut the suture. So whenever I take uterosacral ligament, I keep my two sutures attached like that. So I apply a clip there. So clip is attached there. So now I have one attached there with a clip. So suture where I tied the uterosacral ligament, I just cut the needle and rest of the thread, which is quite long, at least 7-8 inches long, I attach to a clip and I let it hang. And then I go to cardinal ligament. So I do exactly same, and these two I put a clip on the side here. These long stitches, I attach them to the side. For now, so I can manage them after hysterectomy, whatever I want to do with them. So after that, I take the usual steps and I get rid of the uterus. Now uterus is gone now. So when uterus is gone, that is the point when people do McCall's curvoplasty. Yeah. So instead don't do that ever. So now I just close the peritoneum. So I have checked everything, there is no bleeding, and I have just taken a purse string, and this is my vault now, this has all gone, and I have taken a purse string and I have closed peritoneum. So this is all obliterated, and now what I have got in front of me is vaginal vault. Yeah? So this is vaginal vault, and I have got these 4 stitches. If now you think about it, they are still inside the body and the vault is here. So now I get a free Mayo needle, which is like that, and there is a hole there. So I put this string in that hole, and I use that needle to come from inside into the vagina, into the vaginal lumen, because at the moment I am outside. So I come in the vaginal lumen. So I have, now this thread will be coming out here. So I have attached my clip here. Now I do the same, and this thread is now coming out here in the vagina. And I do the same, and now I have got 4 like that. So how does it look now? This is my vault, and I have got a stitch coming out here, 1 stitch here, 1 stitch here, 1 stitch here. So I've got 4. 2 are uterosacral, 2 are cardinal. And now this is my vault. So I just do now anterior repair. This is my anterior repair stitch, and then I close the vault as usual. So this is how it looks at the end. But I feel that, oh my God, it is still lying at the hymen. So what is the point? So now the magic starts, because what I do now then, I take this stitch and I tie it with this while I'm pushing the vagina to the right formus. And then I take this stitch and I tie it with this, so knot comes there, and the thing which was sitting at the hymen has gone right up into the right and left formuses. So I don't know whether this technique has been described in textbook or not, but that's the only way I learned doing vaginal hysterectomy. And luckily, our vaginal hysterectomies, the risk of vault prolapse after them is lower. Some patient, of course, they have it, but this is how. Do you understand how does it look?
Yes.
So at the end,
What
it just
we do, these ligament, we take internal and external McCalls.
Yeah.
In an external McCall, we pass it at the center of the vaginal vault, and
to reduce
later
the
on
stress.
when we pull it, the whole vault
Yeah.
goes up.
So instead
we
of
do
that in the
way.
center, we do it on both sides. So it gives more natural anatomy. So upper vagina doesn't get
Emptying of vagina
yeah.
is
So it is
not
just
there
normal.
that way.
Yeah.
There is
What
about if enterocele is there? If enterocele is there, then
once, just think about it. Why did this lady had prolapse? Because the uterosacral ligament, our cardinal ligaments, they became very loose. So now we have made those 2 ligaments very, very tight, and we have pushed them where they belong. So that's what we hope, that there should not be any more enterocele.
sac has to be dissected and closed.
Yeah, so usually in vaginal hysterectomy, posterior, when we are doing posterior.
Sac is dissected. Look, we are still comfortable in McCalls. Shall we will be more comfortable with our own old McCalls stitch.
That's perfectly fine, as long as you get good results. It doesn't matter what technique we do. Okay, so let's move on. Sacrospinous fixation. Now we have discussed that so extensively so far in this over the course of last few days. So the aim is to fix the vaginal wall to right sacrospinous ligament, avoiding the rectosigmoid on the left side, as Dr. Seema mentioned. But because I do bilateral, so that doesn't bother me. The damaging rectosigmoid. This will maintain a horizontal position of the upper vagina on standing, which will ensure compression and closure of the vagina against pelvic floor muscles upon increased abdominal pressure. So there is a video link as well, whoever wants to see. But another thing I want to mention, that there are 2 types of sacrospinous fixations. So there is anterior approach and there is posterior approach. So this is something which I don't find in the textbook. For example, if somebody is just having an anterior repair, even then sacrospinous technique can be done in for vault prolapse from anterior approach. And posterior approach we all do. So, this does exist, that it can be done, but the dissection is a bit deeper. So this is a bit description that how does it look when we do the single side, which is the right side, standard size. That's a ligament, and that is a device which is just sitting like that on the ligament, and just it has taken three sutures. The one in the middle is non-absorbable. Those two on the sides are absorbable. That's why they can come in the lumen of vagina, and at the end it looks like that. 90% success rate, recurrence rate 5 to 7%. And if you have done very tight sacrospinous fixation, it can result in anterior prolapse. You have to keep that in mind. So not to do very tight.
Another important precaution that is to be taken while taking bite through the sacrospinous ligament, choose the middle part. Don't
Yeah,
go on the upper border or on the lower.
exactly. Because neurovascular bundle is there, upper and lower
Yes.
border. Okay, so we were talking about colpoclysis, and next I have to describe that how do I modify colpoclysis. It is obliteration of the vagina, either partially or totally. I never do total, I always do partial, on the hope of preventing its prolapse. Obviously, patient should be not sexually active. Can be performed in local anesthetic. It is reserved to frail patients who cannot undergo extensive surgery for its short duration and low incidence of complication. The most important thing before doing colpoclysis is doing uterine curettage. So if it is an 85 years old lady, and so when I have booked her in the clinic, when I have seen her in the clinic, I will do a pipelle biopsy at the same time in the clinic. If I don't have access to result of transvaginal scan or endometrial thickness, in the clinic I will do a pipelle biopsy. If I do not get any specimen at all, then I'm reassured it is very atrophic endometrium. But if it is very, and then I don't send the specimen if there is nothing. But if I get very bulky curating with pipal, then I send the specimen and then I see her or give her a phone call after result. But it has never happened so far that somebody will come back with hyperplasia or cancer because they have crossed the age of the peak of the endometrial cancer. But that is in the clinic. But when even in theater, before I start doing colpoclysis, I always dilate the cervix and do a proper curettage, just in case if I have missed anything. And in case, extremely rarely, if I am getting a lot of bulky curettings and patient is under spinal or general anesthetic, then I do vaginal hysterectomy and then I do colpoclysis because I don't want to take that risk of bulky curetting in 85 years old that can come back hyperplasia and then I have to go back abdominally. So in that case, everybody with a uterus, before we actually start colpoclysis, we should dilate the cervix and do a curettage. And if any bulky curetting, vaginal hysterectomy should always written on the consent form. So we can do hysterectomy, close vault, and do colpoclysis. But normally it is extremely uncommon. So I'll tell my technique there. I'll come and draw it. My own statistics, because we have to keep all the strict record of the couple of hundred patients, so 98% success rate. So 2% failure rate. So which is pretty impressive considering it takes only 45 minutes to do it. So, risk of stress incontinence after this surgery. So we offer them post surgery. We don't offer them any major stress incontinence surgery. We offer them bulking surgery, which is again outpatient surgery. So we put a camera in the urethra and we give Bulkamid, which is a bulking agent, on 4 points in urethra, which reduces the lumen of the urethra much smaller, and stress incontinence gets better. So before we move on, I will just describe how do I do that. So the way I explain to my students colpoclysis, if you think about a book with a spiral binding. So it's a book with a spiral binding. This is the spiral binding. So this is front page of the book, this is the last page of the book. And our target is to close the book. So that's how I tell them, and this will be the cervix. Okay? So book is open, our target is to close the book. And that's as simple as that. So how do I describe that? So, so this is our patient, and this is uterus and cervix coming out like that. So
last time. Everything is 10 centimeter outside. So this is cervix. So first thing I do a curettage. So I have not received anything. So then I have a marker pen, which I use a marker pen. So this is urethra now. Urethra is here. So I give quite a lot of space, 3-4 centimeters. So I will draw a rectangle like that. And I will draw a similar rectangle on the other side. And then I'll use a lot of local infiltration, bupivacaine and adrenaline, and I will remove the skin of this rectangle and I will remove the skin of this rectangle. So cervix is here. Now I have two rectangles there. So in the traditional colpoclysis, there is mention of a lot of layers of closure. I don't do a lot, I just do 4. So what I do, so this is cervix. So these are my rectangles now. So my first stitch is from here till here. Second stitch is here till here, here till here. So I get a view then like that. So I have invaginated the cervix. So this has been closed with this. So cervix has gone back up. So now it looks like that. Then I take this stitch with this with this. So gradually I start closing this side with this side with this, and this will keep going up. So just imagine a book with the spiral binding. So the book is open. So cervix is here. So now with every gradual stitches, cervix keeps going up. So at the end, the last, this part, when I close with this, the cervix will go up completely and this book will close like that. So now at the start, the cervix was lying here and now cervix is lying on the top and the shorter side of rectangles I have closed. But there must be at least 3 centimeter underneath urethra which I need to leave. So in the book, textbook, they tell gradual suture line this and this and this and this. So you keep suturing. There is no need because there is raw area. So it will close like this only. We are doing like this only.
One more. We have not taken that much 3 centimeter.
But very few. It's not very popular with us.
I
I've only done
somehow
this.
I am putting a catheter or some tube into the cervix will prevent it from
3 centimeter
like going into the behind the stitch. So when we are stitching it, just put a tube
You can
into
do
the
that. You
cervix.
can do that as well.
On either side of each side.
Single barrel is converted to double barrel for the
Yeah,
drainage purpose.
you can do that as well. I think we are nearly there for this part. This is probably the last slide. We talked about sacrospinous fixation. It is uterosacral ligament suspension. I think this video we should see. This is a good one because this is a bit different. Vaginally, we can do when the enterocoel is open and bowel is reduced, and abdominally as well, it can be done. So I don't know which clip is it. Can you please? Um, I don't know whether it is vaginal. I want to show the abdominal one. You open this and then I'll remember. There are two clips actually. Um, the second one, this one. This is with robotic surgery.
I'm Elizabeth Coronado, robotic surgeon, here to talk a little bit today about the uterosacral ligament suspension and best steps to get your best outcome.
It's a quick video.
You're going to need 2O Ethibond permanent sutures. The purpose of a uterosacral ligament suspension is really to bring the top of the vagina up higher.
You see I've identified the ureter there, peristalsing laterally. I'm going to grab the uterosacral ligament 2 centimeters above the vaginal cuff and put my 2O ethibond suture through it and tie kind of my stay suture knot. It's important to remember that this is permanent suture, so we really don't want it running through the vaginal tissue because it's not going to dissolve. So as I pick up my vaginal cuff, I want to pick it up with deep enough tissue bites that I have a good outcome and good support, but not so deep that my suture threatens to actually enter the vaginal mucosa. So I'm going to pick up a posterior aspect of the cuff, and then I'm going to pick up an anterior or front part of the vaginal cuff that I've already repaired after the hysterectomy, pushing the bladder away there. I'm going to bring that to my stay suture and tie it together. Now this is a pretty slippery suture, so my assistant's going to come in and hold it for me, which I would recommend doing just to avoid frustration. And you see I'm tying surgeon knots on the first 2 sutures, and then my last 4 knots are simple knots. It's really important as we do this to ensure that the ureter obviously is kinked, which is why we identify it ahead of time, or even universal cystoscopy, so that we can look in the bladder, make sure the ureter looks good. So there's our left ureter peristalsing, and we're just going to repeat the same steps on the left side. This is going to give your patient their best vaginal support. If you can see on their exam,
Okay, so in the interest of time, the link is there, and whenever you get time, you can watch the video. So after that, it was, so we discussed sacrospinous ligament fixation, we discussed uterosacral ligament suspension, we discussed hysteropaxy, and we discussed colpoclysis. So from small to major, we have discussed all the surgery for prolapse. So the next part was surgery for stress incontinence. So that is very simple. The reason, because there are not many surgeries which we do for treatment of stress incontinence. So conservative management we have already done. So the simplest surgery which we do for stress incontinence is the bulking agent. So in the past, people used to use macroplastic and different type of things which we injected in the urethra. Now we only do one single agent, which is polyacrylamide gel. It is water-based gel, and it comes in the market with the name of Bulkamid. Okay, so it's 2 syringes, 1 ml in each syringe. So there is a little scope which is very small, just the size of my hand. So this scope only goes into the urethra. We can go in the bladder and have a quick look to make sure everything is normal. So in urethra, we look at the urethral meatus, and the first thing we do, we give local anesthetic. I think we can.
that they seem
Shall
to
we
have
finish it?
some uterine prolapse.
Let's
or
finish
vaginal
this one.
Apex prolapse. This is really going to give them their best outcome.
Sorry?
For patients, if you're suffering with prolapse, you might want to ask your physician that's doing your robotic surgery if they think that a uterosacral ligament suspension is for you. We're going to remove the suture here. That other chromic suture at the bottom was a support stitch that I put into the cup of the vagina. Just as I was doing this, I felt like it needed one more support suture. So we're going to remove all of our sutures through our assistant ports and just review the steps one more time. Remember that the uterosacral ligament suspension will...
Okay. So this is just the anatomy of uterosacral ligament and where to take stitches, but it is mandatory to do cystoscopy after that to see the urine coming out of both ureters, because you can easily kink the ureter in this one. So it's not a simple procedure.
That means cystoscopy is must after uterosacral ligament. Yeah, it's a must. And if you have any doubt, you can give 2 mils of indigo carmine IV, and then urine becomes blue. Then it's easier to see. Because sometimes when ureter is partially kinked, the jet is slower jet. So you see the jet, but actually it's slower. So you want fast jet, and you can see it clearly if it is indigo carmine blue urine. So anesthetist will give that for you. So then the urine will become blue, and when it comes out with a fast jet, it is perfect ureter. But if it is like sluggish jet, then it is partially kinked. Okay, so sacrocolpopexy we already discussed. So this is recurrent prolapse. We were talking about that we can offer them pessary if it is recurrent prolapse. We should not keep pushing for more prolapse surgery because recurrent surgery is very difficult because of adhesions and scarring and higher risk of bladder and rectal damage. So if somebody has recurrent prolapse, ask them to lose weight, do exercise, start the journey again. Never ever jump to do recurrent surgery again. Surgery is difficult when it is recurrent surgery. Use of mesh. So in the UK, it is illegal to use any vaginal mesh. As we said, only mesh which is allowed is sacrocolpopexy mesh. So that is the first thing everybody needs to know. So some centers in Scotland and Ireland, they have started to use TVT again, but only they are allowed in research setting. So they have started to do research. So if somebody is sitting here for part 3 exam, you need to know that if a patient role player will say, I only want TVT. So this is one of the stations. When the patient is given instructions, she said, oh, I have done my research. Now only operation I want is just TVT. I don't want anything else. So that is your job to tell her, by law, you cannot do that. You are not allowed to do that, even if she wants it. And even if she says, I accept all the risk and I'll sign it. But if you do it, you will go to jail because it's illegal in England to use mesh. So that's true. It is a crime because it will come in body mutilation, because something which has been banned by law. Apart from the situation in Scotland and Ireland where they are using in research setting, so they have got approval from MHRA. So that's why use of mesh is very controversial nowadays.
Means sacral colpopexy, you are attaching this mesh from the anterior part of the cervix to till the this.
So it's a Y-shaped mesh. So we do dissection on the anterior vaginal wall and posterior vaginal wall. So we put one limb of Y anteriorly, one limb of Y posteriorly, and the stem of the Y to sacrum. Yeah, yeah. Biological graft. So there was a mention from biological graft. So the sling operation which we use for stress incontinence surgery, that is patient's rectus sheath. So now some centers, I know there is one center in South Wales.
You have to go below the uterine or it's just above the.
So that is for vault prolapse. So hysterectomy has been done. So the uterine sacrohysteropexy, you go above through broad ligaments. Bec-
Should be the mesh should be below the medial to the uterine artery, or it should be above.
above, because below will be ureter, isn't it?
No, no, no. If we are doing sacrohysteropexy,
Yeah,
like there are two methods.
yeah, yeah.
Either you will go like above the uterine cavity, that means the mesh will come lateral to the uterine cavity. But it is said that once the patient will get conception,
Yeah.
it will stretches. Has to be same. So discussion हुआ है. अच्छा, it is said we have discussed that.
हाँ हाँ.
Uterine से medial जाना है. Medial.
So maybe what Dr. Shaheen is trying to ascertain that when she becomes pregnant, what happens, because it will not distend that much. Yeah, so the part of the uterus which distends is actually above the internal os. So the mesh is at the level of below internal os, isthmus. So when pregnancy happens, the cervix size remains the same, but everything upward, it grows upwards. So that's why there is not much change to the actual mesh, because uterus grows upwards. Just like when bladder gets filled, there is no change to urethra or trigone. They remain same size, but the bladder fills up upwards. Similarly, uterus also grows upwards. So that's why the mesh is not affected with pregnancy. And people must have cesarean section though. Yeah. Okay, biological grafts. So there are grafts which come from cows or pigs, which can be used, but we don't like using them as well because it's a foreign body. And although they have not been banned completely from the UK practice, but we don't like using any mesh because of the controversy. Why to make your life difficult? The only thing I use is rectus sheath thing, which I use for stress incontinence. We'll mention that. But there is a center in South Wales. So they have started taking allografts from rectus sheath to use it as sacrocolpopexy instead of the mesh. To use the piece of rectus sheath, attach it to top of the vagina and attach it to the sacrum in place of the mesh. So research has been started there because we have been using the similar type of for stress incontinence. So they have started the research. So maybe in future, fascia lata from the thigh, it is more useful, isn't it? Because we can take a lot bigger piece, can be used for sacrocolpopexy.
We did with the rectus sheath, but with the uterus intact, we have attached the, like after cutting the separating the rectus sheath, we have taken out the rectus sheath from the that round ligament and then attached to that anterior part of the cervix.
Yeah,
But it
that's
was not that useful.
okay.
After some times, the prolapse
Hmm. Yeah.
it
Yeah.
won't give much support.
No, because round ligament is very flimsy, isn't it?
If you see the history of different surgery for sacroiliostopexy, these are the older methods.
Sling,
These are
sling.
older. See, it's the
Okay.
rectus sheath, but it is not that.
No.
There is a history of surgery for like prolapse, hysterosacropexy. These are the older method, and the most latest is the mesh.
Okay.
One mesh is the
All right.
2021.
Yeah.
It
Tea
was
break?
invented.
Is it? We are nearly done. Let's see. Yeah. So these are few cases we can do later on. I think I'm talking too long.
No, ma'am, that's good.
Thank you.
Yeah, like give this back. As all the knowledge is collected, hence we use this platform of the